Welcome to the show. When you think of Olympic athletes, you think of the epitome of health, a dedicated group of individuals whose whole life revolves around health, well being, and pure performance. Individuals who would be a cardiologist's dream patient, the poster child of compliance. The last thing you would think of with some of the fittest men and women in the world is their risk for a heart attack. Now, while endurance exercise can provide powerful protection against heart disease, it turns out it also has the potential in some athletes to bring on a troublesome arrhythmia called atrial fibrillation, or AFib. And over the next hour, we are going to talk about AFib, what it is, who's at risk, and why complications stemming from it are leading to people having a heart attack. We're also going to talk about some treatment options that are available. We have electrophysiologist and cardiologist Dr. Joseph Bumgarner, who's with us. He is from UNC Rex Healthcare in North Carolina, and we're going to get to him in just a moment. But first, hello, John. How are you?
So happy Saturday, Kim. I'm sorry I'm laughing. I was just as we went on air, my office window overlooks my driveway, and I see my son has a dirt bike, which it's like electric, but it can go like 25 miles an hour, and he's supposed to wear a helmet, and he's flying down the driveway with no shirt on,
Oh.
no helmet, and he's holding a fishing rod in one hand. So I am just, scratching my head. I'm a little vexed right now. So anyway, yes, I'm
So at the
happy.
commercial break, you were going to see him running down the street after his child.
Anyway, yes,
That's awesome.
an interesting topic for today, and we were sharing before we went on. We don't typically have electricians on the show, and mainly plumbers, so this is a good change of pace.
Mhm.
But I wanted to start the show with a little bit of a sad commentary and a very sobering kind of experience that I had with a patient. So, and I don't think this, obviously, with HIPAA, we're not going to share this gentleman's name. But so I ended up seeing a gentleman who was admitted to our hospital on Friday after a suicide attempt.
Oh
And
no.
we don't, so again, I saw him for a vascular issue. Well, I came to find out that this gentleman was having so much pain in his foot because of ischemia and lack of blood flow.
Yep.
And he had gone to several facilities, I believe in our area, multiple attempts at revascularization to improve his plumbing that failed. And so he decided that he was going to kind of end it. And he wrote, and I have he wrote a suicide note, honestly. And I'm going to read it here because this just kind of shook us. And I remember it was in his chart, and so we all kind of read it after the procedure that I did. But it basically said, "I can't take the pain anymore. This has always been my destiny. Just want all the pain to stop." So I started to wrap my head around that, thinking, what a failure, right? Like this poor guy is asking for help. We, meaning the healthcare system, couldn't get him the help he needed, and he was considering taking. Actually, he had tried to overdose on fentanyl or something, and thankfully somebody saved him. He ended up getting taken to our hospital, and so I did a procedure, and we got some blood flow back, and he actually was very thankful on a number of levels. But it was just so sad to me and sobering. But what I told my team was because they love me, I think, but sometimes they're like, oh, he's doing another one of these pedal access things, and okay, crazy procedure type stuff. But I said, guys, this is why we do this. This is
Yeah.
why we do this. And again, you and I have talked about this many times, but I've never seen an attempted suicide because of foot pain due to ischemia before. So again,
Oh,
we've just got to keep our finger on the pulse here and raise awareness and continue to educate folks as we push on.
this is something that we see actually at the Global PAD Association every day. And doctors tell me that they think it's just, oh, that's just an isolated case. That's the exception to the rule. They don't understand. I don't think, I mean, honestly, do not think, and you can probably weigh in on this. Did you think, after I say this, that PAD is this debilitating? PAD is one of the most debilitating diseases that is so under addressed. And when I hear doctors every day fighting for their own limitations and putting things out in the media, saying that these patients should not be treated. Don't treat them too soon. Let's just wait till they're a toe step away from amputation. Let's wait until they overdose on fentanyl. Let's wait till they decide that they're going to steal items from Walmart just so that they could go to jail. Remember that story?
Yep.
The patient,
I forgot about that.
Dr. Bumgarner is here too. You can always join in, Dr. Bumgarner. John and I could go on forever, but there was a patient that we had on recently that she actually was in so much pain and was being ignored by doctors. She didn't want to be a burden on the healthcare system or on her family anymore, couldn't afford it. Insurance was gone. So she pretended that she was going to steal items from Walmart, stood at the door waiting for the police to come. And the police said, "Why did you do it?" She said, "I just don't want to be a burden on my family. This ischemic pain is too much for me. I need to go to jail so I can get the care I need." And that's sad. That's the reality of what we are seeing every day. And this is actually the 4th suicide attempt that I have heard of from PAD in just the last year. This is the first one that was not with us, but we've had 3 in the past year that we've had to help talk down from the ledge. It's really a debilitating disorder and should never get this far. It needs to be taken seriously.
Yeah, sir. A lot to digest there and unpack, but at the end of the day, this gentleman had options. He didn't know what his options were. We failed him as a healthcare system, and he almost lost his life. And then to actually to put more salt in the wound, he worked at this facility for 25 years. I forget what he did, and then his boss fired him because he didn't show up for work. I mean, it's like these people can't get a break.
No, not at all.
And I don't want to belabor the point, but it's just really, it's frustrating because there's a lot of good that can be done, and a lot of good done by you, Cam, and your team.
And there's a lot of good to be done by your team. You are Dr. Miracle this week, because we had a patient that was not being heard by her doctor, happened to be someone that a doctor that you knew, and you took a risk and you said, "Hey, you know what, let me just take a look at this patient. Let me see if a different set of eyes can do something." And it turns out that something could be done, and you were willing to take the leap and actually do it. And this patient calls you Dr. Miracle now. And we appreciate you for literally going out of your way to save some patients.
Honestly, and Joe can probably attest to this, I think most of us are pretty humble. It's just kind of part of what we do, and we're very thankful that people appreciate it. But honestly, I don't know that I went above and beyond. It was just kind of an assessment that we made as a team. And I just, again, we weigh risk versus benefit and reward and whatnot. And it was pretty easy proposition for me. So hopefully she does well, and happy to help. Very sweet family.
Just always making sure you're taking a patient-centric approach to practicing medicine. Well, coming up right here on the Heart of Innovation, we'll take a moment to introduce you to Dr. Joseph Bumgarner. He has been sitting on the sidelines waiting to jump in, and we'll hear some of his life and limb-saving stories coming up in a moment. So stay with us right here on the Heart of Innovation.
How many procedures are you willing to go through? Is it worth going through that many, or would you rather just cut
That's funny. Was it worth it? Oh yeah, I have my leg, man.
Amputation should absolutely, positively, 100% never be a first-line treatment.
What an incredible operation, what an incredible lab you have here.
Without a doubt, we're underdiagnosing peripheral arterial disease. It has not gotten the attention that it should, because it is a killing disease, it is a disabling disease, and most importantly, it's a disease that we now have great treatments for. Okay, let's go to the next one.
They were going to amputate it, and I needed to consult with my family. Did I want it off here or here? You're just shocked. It's scary. I don't even know how to explain it. You're 42 years old.
We're waiting till people are at the end of the spectrum and almost beyond hope. There is good care available here. Closed minds are what we have to get rid of.
Dr. John Phillips' spectacular vascular moment of inspiration.
Just as though like the fog kind of lifts and the sun is, shines through, the sobering comments that I made are all kind of washed away when we hear the noise of the moment of inspiration. So
I love it.
On the heels of the Olympics, the Olympic Games in Paris starting, I have a quote from Pierre de Coubertin. I'm sure I'm mangling his name. He's a French educator and historian and considered the founder of the International Olympic Committee. And he's quoted as saying, "The important thing in the Olympic Games is not to win, but to take part. The important thing in life is not triumph, but the struggle. The essential thing is not to have conquered, but to have fought well." What do you think, Kim?
Wow. I wouldn't apply that to medicine because I always want to win. I always want those piggies saved.
Well,
We
but
piggies for the win.
that's
No,
true.
but I
Try to
get what
save the
you're saying.
piggies, but
It
right. I
is.
mean, like
But
you got to fight the
hey,
fight.
you do. You got to take the leap. You got to try. And there was a quote that I shared with you from a good friend of mine, Candace Barr, that she was saying that you need to not fight for your own limitations. You need to always take the leap. You need to fight, fight, fight. And I think that you're the epitome of that. Dr. Bumgarner's the epitome of that. I think one of his colleagues, Dr. George Adams, is definitely the epitome of that. So all of you doctors that are literally fighting for life and limb every day, definitely are the poster children of your quote.
Well, thank you. So let's welcome Dr. Joseph Bumgarner to the show, an electrophysiologist from North Carolina. Joe, how you doing? Thanks for joining us. Happy Saturday. How's the weather down in NC?
Hey guys, thanks for having me. Well, it is beautiful. It's about 90 degrees here. One interesting fact about George Adams is that he drives an F450 with a cattle trailer attached to it to the hospital, and he inspired me. I have one as well, and I spent my morning washing it, and so it's been a good day so far.
A 450? So is that like a dually or something?
It is. It's embarrassingly large.
Awesome.
And, are you herding cattle as well?
No, I have 3 wonderful daughters, and that's enough for me.
That can be like herding cattle.
Does a truck like that fit in a normal parking spot?
So it perfectly fits line to line by most standard parking spaces, but you've got to get it just right for it to fit.
Awesome. So speaking of getting it just right, tell us about atrial fibrillation. So the lead into the show was Olympic athletes and potentially having an increased risk of dysrhythmias or abnormal heart rhythms. Tell us how you got into the electrical world as a cardiologist and why you have some fascination with Olympic athletes and atrial fibrillation.
Yeah, so I would just say that, like most of us, the reason we find our way into things is the mentors that guide us and kind of the people that come in our way. I just happened to fall into a job working with an electrophysiologist in Wilmington, North Carolina, at the beach, which was pretty inspiring. And we just had a blast learning about this world of electrophysiology. I knew that I loved cardiology. I knew that I loved blood vessels and opening blocked arteries and heart attacks and all of that, but I didn't really realize that there was this whole other world of, electrical conduction problems with the heart, and that there were opportunities in that field to really impact patients, to really impact their quality of life, especially with certain arrhythmias. The word cure was being used in this clinic, and I couldn't believe that. We were managing high blood pressure and managing coronary artery disease, but then we were curing certain arrhythmias. And then being in EP or electrophysiology, you just can't practice that without being surrounded by atrial fibrillation. It is the fastest growing sort of public health epidemic around the planet, and it is just growing by leaps and bounds. We don't fully understand why, but what's interesting about it is there's this dichotomy. It happens in patients that are chronically ill, that have a lot of other health issues. And then the longer you practice, you discover it happens in very healthy young people that are doing the right thing. And so it sort of, in a way, found me. I have this wonderful group of athletes and cyclists and marathon runners that are developing atrial fibrillation. And it's just a curiosity of why that happens.
That must be so frustrating for these patients, and something that you say, you know what, I know you're doing the right thing, and they must come back at you and say, is there such thing as too much of a good thing, doc? And how do you respond to that?
Well, it's a great question. And I think I think that at some level, it probably is too much of a good thing. I think, our heart is a muscle. Our heart is an electrical system. It has a certain optimal running speed. The best heart rates to develop cardioprotective benefits are not max heart rates. And they're not heart rates that last forever. It's really just a contained amount of time, 30 minutes to an hour, most days a week, getting your heart rate into that 50 to 70% peak heart rate range. That's where most of the cardiac benefit lives. And so a lot of athletes are really outside of that range. And I think over time, like any muscle, it puts it under extra stress.
So can you go into the basics? Sorry, I was going to ask you go into the basics of atrial fibrillation. Like, what is it? What is the mechanism of action for this particular disorder?
Yeah, Afib is the most common arrhythmia that we see. And I think to talk about it, I always like to talk to my patients about what normal is. Normal in our hearts, I describe our hearts kind of like a house with an upstairs and a downstairs. The downstairs are the ventricles, the downstairs are the big muscular chambers that are beating, but they really don't beat on their own very well, and they need a pacemaker. They need an instruction from the top floor of the house. And so we're built with a pacemaker that lives in the top right-hand corner of our house, and it sets the rhythm of our heart beat after beat. And we have about 1 million heartbeats every 2 weeks. It's miraculous. It's amazing. It starts when we're about a month old in our mother's womb, carries us through our whole life. But there are other pacemakers that, if you wind the clock back when our heart is forming, and our heart's really just a tube, and it hasn't twisted and turned into that 2-story house as I was describing, our natural pacemaker, another part of the heart called the AV node, and then this extra part called the pulmonary veins. The pulmonary veins, all three of those things, the sinus node, the AV node, and the pulmonary veins, they all originate actually from the same place from a congenital perspective. And so as you fast forward through life, there are other areas of the heart that can fire like a pacemaker, can fire like this spark plug that makes the heart beat. And so the pulmonary veins are the source of the bad electrical sparks that can spin the heart out of control into AFib. And what happens is those top chambers, rather than beating in a very organized way like they normally do when we're in normal rhythm, they just sort of quiver because that electricity is beating in a very erratic way. And it causes the heart to beat too quickly, too slowly, erratically, irregularly, and it can be pretty uncomfortable.
Well, coming up right here on the Heart of Innovation, we'll have more with Dr. Joseph Bumgarner with UNC Rex Hospital in North Carolina. So stay with us right here on the Heart of Innovation. Don't go away.
Your type of condition is called critical limb ischemia. It's the most advanced form of PAD or peripheral arterial disease.
Every 4 minutes, there is an amputation in this country due to PAD and diabetes. We also know that 85% of these amputations are preventable with early intervention.
It's a flip of the coin. Patient prognosis is tied to whether or not they are referred to a true expert in the management of peripheral arterial disease.
Do you know if your physician is an experienced CLI operator?
When you're in the hospital dealing with doctors and stuff, you figure they know what they're talking about.
The skill level varies doctor from doctor and hospital to hospital.
Patients with limb threat are in constant fear. The depression that someone experiences after they lose a limb is equivalent to those of losing their spouse of 40 years.
I was stuck in a wheelchair close to 2 years and my husband had to quit work.
I didn't know what to do at this point because we had nothing but infections and hospital stays and infections and hospital stays.
And they took one toe, another toe, and then it was another toe, and then half his foot before he was even diagnosed with PAD.
And all I heard was, "What are we doing here? Just cut it off." And I pulled the curtain back like, "Are you kidding me?"
Do you really want to go through all that?
That's crazy. That's insane.
The protocol is to send them to amputation. Always, always, always get multiple opinions.
We do have options.
We need to listen more to our patients.
If you're going to chop off their leg anyway, why not just let someone else try?
This is the progression. First comes the wounds, and then comes an amputation. And I wasn't going to accept that.
So that's what it's like to try to save a leg.
Welcome back, everybody. Thank you for joining us. We are starting to scratch the surface on the most common most common dysrhythmia in the United States and the world wide, I believe, atrial fibrillation. And Dr. Bumgarner was sharing with us a wonderful analogy about a house and 2 stories and making sure that the kind of the pacemakers from the top are acting appropriately, and oftentimes they don't in atrial fibrillation. So, Joe, we know that atrial fibrillation is a problem in and of itself with respect to the heart not beating right, but there's also risk of blood clot forming and stroke. So it's kind of like a double whammy, right?
Yeah, it's, AFib, and I always tell my patients, look, AFib is not a life-threatening rhythm. It might be a quality of life altering rhythm, but I always tell them there are 2 rules. And the first one is no strokes allowed. So in 2024, we really should not be having strokes from atrial fibrillation or blood clots. And thankfully, we have some great medical options to treat that. And then the other side, the other rule that I have is no heart failure allowed, because when the heart runs too quickly and too erratically in AFib for too long, it just wears out. It's just the extreme. Imagine you exercise. Imagine you're running constantly. That's what AFib is. And if the heart doesn't have time to rest, it's a muscle. At some point, it just fatigues and wears out.
So what
Do most
typically actually
people?
triggers? We're just bombarding you. It's like the
We
firing
are.
squad.
Too many questions. Exactly, firing inappropriately. We're firing inappropriately,
Exactly.
Kim, and we're having AFib on this
We're just
interview.
staying on topic as always.
Exactly.
You couldn't have more fun in an interview.
No, you couldn't.
Dr. Joe. So what was your question, Dr.
Mine
John?
was like, and I know the answer to this, but I want Joe to explain it. Does everyone know they're in AFib? Like, do you?
Oh,
right? Because you
what
said
a
it's like
great
running.
question.
Yeah.
What a great question. And so I think doing this long enough, I do believe there are people that don't know that they're in AFib and really can't tell the difference between what normal feels like and what AFib feels like. And I would say it's actually miraculous. We don't feel this muscle in our chest beating all the time, but we don't, which is amazing. But what I always challenge my patients with, if I meet someone that's in AFib and they tell me, I don't feel it, I feel fine, I'm doing well, I'm okay, I say that is okay, but let's prove it. And so I usually do what's called a trial of normal rhythm. And so we usually use a medicine, or we do what's called a cardioversion, which is an electrical resetting of the heart rhythm back to normal. And then I see them back. An example, I saw a patient this week, completely asymptomatic, of course, super athletic, great guy. We did a cardioversion and I saw him 5 days later, and he says, I feel like a new person. I realized I was carrying a backpack on my back for the last 3 months and I had no idea. And now I sleep better, I exercise better, I feel more like myself. So I always sort of challenge them in that regard.
See, that's the sign, though, of a good doctor. Asymptomatic is not necessarily asymptomatic. It's the doctor not asking the right questions to determine if the patient is, in fact, asymptomatic. But of course, looking back, the patient will look back and go, wow, I was symptomatic, right?
That's
and
right.
I think that that's the case with a lot of these patients. I also find that with PAD patients, that the patients just don't realize they're walking slower to protect themselves, to prevent the onset of claudication.
That's right. And just like PAD becomes so critical at a certain point, AFib becomes so critical too when, the worst part of my job is meeting someone that has just had a massive stroke and they didn't know that they had AFib. And so that's why you see companies like Apple building in an algorithm into the Apple Watch, or you see another company like Cardia putting a home EKG monitor out on the market, is that, this is really a public health issue where we can really reduce the risk of stroke for so many people around the world just by detecting AFib.
Why is AFib so rampant? Who's at risk? What triggers it?
The answer I usually give is yes. It is part of being human, and I don't fully understand it. At the microscopic level, it gets down to calcification, the same stuff that causes stiff joints and arthritis, the same stuff that causes macular degeneration. It is part of the stiffening and the aging of the heart muscle. There's no question. Is that the electrical connections, cell to cell, when they start to get filled with calcium in the spaces between cells, electricity just doesn't move as well. Sometimes during an EP study, when I have a teenager that has a specific kind of condition in the EP lab, part of my job is to put them into Afib. I can pace aggressively enough in the EP lab and put them into Afib. And that's not that difficult to do. We all can go into Afib, but it's the sustaining of that rhythm. It's the keeping it going. That 15-year-old, 16-year-old, they're going to snap back to normal rhythm in a matter of seconds. The 40-year-old, the 60-year-old, the 80-year-old, they've built an environment in their heart where that spark can set off the fire and the fire can keep burning. But what causes it? So many things: high blood pressure, sleep apnea, obesity, poor diet, sleep apnea. Again, that's a huge one. So I'll say it twice.
But Joe, isn't it a function of just an aging population? I mean, I think, what is it? What percentage of people over 80 have AFib? For some reason, 20% or something like that sticks in my head. I don't know if that's right, but we're living longer, and people are getting AFib. But so how do you manage it? Like, tell us about the treatment options, not only for the rhythm issue, but then to prevent stroke.
Exactly. So there, just as you say, there are kind of two sides to treating AFib. And the most important one is protecting someone from stroke. Now, not everyone that has AFib needs to be on a blood thinner. Young people that don't have other risk factors, their risk is just not high enough. And so we don't start powerful blood thinners in those patients. But when you build up enough risk factors, things like high blood pressure, previous heart attacks, vascular disease like PAD, age, being over 65, being over 75, there are risk score calculators that we use in clinic to talk to patients about, hey, your risk of stroke is 3% in the next year. There's a medicine that can bring it back down essentially to zero. And so we have those conversations. And so there's that side of treating AFib to prevent a stroke. But then there's the other side, and that's all about symptoms, and that's all about quality of life. That's all about keeping the heart in normal rhythm. And historically, there was this idea that keeping the heart slow, or what we call rate control, was a good way to control AFib. But over the decades, since the 1980s, tons and tons and tons of evidence tells us that rhythm control, keeping someone's heart rhythm, not the speed, but the rhythm in a normal rhythm, is so much more important. People feel better. Their risk of heart failure is lower. Their risk of stroke is lower. Their risk of dementia is lower. And so using certain antiarrhythmic medicines is an option. But I think for a lot of us, and for, the American Heart Association and Heart Rhythm Society, there's been this big move towards a procedure called ablation. And so most EP cardiologists, we spend most of our time doing ablations for atrial fibrillation, which is a process of just silencing those pulmonary veins and those kind of spark plugs that are firing inappropriately from those pulmonary veins.
What, real quick, because we've got about a minute and a half left, what do you quote your patients from a success standpoint and durability standpoint for an AFib ablation? Say it's the first one, because obviously they can have multiple, right?
Yeah, that's right. It has to do with how long they've had AFib. So for someone that has short episodes, a single ablation with current technology, the success is above 90%. One ablation, the likelihood of freedom from clinical AFib 5+ years, we would say is greater than 90%. If you wait, if you sit on it and you let AFib fester and get a root and a foothold, then that starts to come down. And for somebody that's in AFib all the time, maybe weeks or months at a time, I might say more around the 80% likelihood that a single ablation, not using medicines, but just the ablation alone, would keep them in normal rhythm with a single treatment.
And coming up right here on the Heart of Innovation, we'll also talk about some cutting edge treatments such as the Watchman. And we do have some questions coming in from our live studio audience. So stay with us. Don't go away. Keep watching the Heart of Innovation.
When your sugar runs high, it's more than a sign. Diabetes creeping in, it's a dangerous line. Pre-diabetes too, don't think it's too light. It can lead to PAT, so start the fight. Sugar's sweet, but the cost is real. High blood sugar makes your arteries feel clogged. Slow flow, it's a ticking time bomb. Catch it early, stay strong, and keep your legs on. Sugar's not so sweet when your leg is in pain. Not controlling sugar is where peripheral artery disease sets in. Got sugar? Get checked. Don't wait too late. Save your legs, save your life. Take control of your fate. Leg
Welcome back, everybody. Thanks for joining us. Let's continue our conversation with Dr. Bumgarner regarding atrial fibrillation. Joe, so as we went to break, you were kind of sharing with us some of the treatment options. Before you get into, so let me ask you this. There are some people that need anticoagulation, and if I remember correctly, the folks that are at highest risk based on their scoring system, which you had alluded to, often don't get anticoagulated because they're at risk for a fall or things of that nature. So now we have a minimally invasive way to help reduce the risk in these folks. Is that right?
That's right. So a lot of patients, they're at risk of falling. They've had bleeding in the past. They've had bad GI bleeds. And so they just can't take these medicines. And so in those patients, over the last decade, there's been a device that's come really into the spotlight called Watchman. And it is essentially, I would describe it to my patients, imagine a plug in your bathtub or your kitchen sink. That's what it is. So there's this part of the heart called the left atrial appendage. We have known that's a problem in AFib for decades. If you have open heart surgery today, and you have AFib, a surgeon will cut that off. This little pouch, this little windsock that hangs off the side of the heart, it doesn't serve any function except that it has a lot of nooks and crannies and blood clots form in there. In AFib, they can form, then bounce out and cause a stroke or a clot somewhere else in the body. And so Watchman is where we target that windsock, that extra appendage on the heart, and we essentially seal it with this device.
Does that mean once you have the Watchman in place, so two follow-ups. Once you have the Watchman in place, so you no longer need anticoagulation moving forward, assuming it's successful? That's my first question. And then my second question is, out of the clot that people get from a stroke from AFib is what percentage? 90+% from the appendage? Is that what you tell folks?
I would say it's above 95%.
Okay.
There's no question. There's this inflammatory issue with AFib where clots can form in other places in the heart, but the vast majority form in the left atrial appendage. The issue about continuing anticoagulants after a Watchman, that's always a shifting ground, but the FDA recently approved dual antiplatelet aspirin Plavix or another combination for 6 weeks after a Watchman, and then usually just aspirin alone as a single antiplatelet. So yes, they can actually get completely free. They can become free of their anticoagulant.
What's the maintenance, durability, and indications for the use of a Watchman?
So the Watchman itself really just creates a scaffolding where the body, the human heart, regrows a layer of tissue over the top. And so it's actually the patient that is sealing the appendage. The Watchman's not a filter. It isn't a plug that has to be changed or removed. It essentially closes off the part of the heart that forms these clots. And so it's a lifetime decision. It's durable for the rest of the patient's life.
Wow. And what are the indications for its use? When do you know that you need one? Medication's not enough. Other options, cardioablation, not a fit for this patient.
That's right. So the biggest one is risk of bleeding. So in a patient that has a risk of stroke that's very high, but at the same time they have a risk of bleeding that's also very high, that is the ideal patient for a Watchman. A patient that's taking Eliquis or taking Xarelto and having no issues whatsoever, that's really not the right patient for a Watchman. That's a great way to protect them from having a stroke, just taking that medicine. But for that patient that can't tolerate it, either through an allergy or through bleeding complications or fall risk, those are the patients that are best served by a Watchman.
Joe, that was going to be my next.
Real quick, if I could, sorry, I know we got to get to some of the guests, but follow-up question. Do you ever think, Joe, that in the future we may just be putting Watchman in everybody and avoiding anticoagulation?
It's very similar to TAVR or the transcutaneous valves. They initially were just put in the sickest of the sick. Watchman was the same. We put it in the sickest of the sick patients, and we see that kind of eroding back down into moderate risk patients. And I hope so one day. I think it's proving to be very effective, and a lot of patients are getting great benefit out of that. In the same way they got benefit out of just clipping the appendage or cutting it off at surgery. It's just a minimally invasive way to do what we've been doing for decades.
I know a lot of patients that would prefer just this one-off, procedure versus having to take their blood thinners every day and the bruising and the bleeding that happen just when you look at them. So that'll be interesting to see how that evolves. Nancy, go ahead and ask Joseph Bumgarner your question.
Okay. My heart stopped beating. Luckily, I had an EMT there who started giving me CPR. I was flatlined. The ambulance came, they got the paddles on me, they got my heart going, stabilized me in the hospital, put 2 stents in, and determined I needed a defibrillator, so they put a defibrillator in. It's been 9 years since that happened, and I have peripheral artery disease, and I do a lot of strenuous exercise. I'm back to it now. I line dance, and that's when my heart stopped. I was line dancing. My question is, should I watch my heart rate? How much exercise? Should I know when to stop? I didn't know when my heart was beating, felt like it was beating out of my chest. So I think that's when I had that arrhythmia, before I had the heart attack, before all this happened. So my thing is, what should I do now? Should I be careful? Because I'm afraid at times that it's going to happen again.
That's a great question. Thanks so much for that question, and I'm so glad you're doing well. Can I ask you a question quickly? Has that defibrillator ever had to fire or shock you over these 9 years?
No, but my original defibrillator was a Medtronic, and it went bad. And it was the strangest thing in the world because there was these sounds coming out of my chest, and they were with a St. Jude medical device defibrillator. So since then I've been fine. It has never gone off.
That's great. And I think you made the right decision to have that put in. I have patients that play sports, play soccer, basketball. I have a professional skydiver that has a defibrillator. And so my advice to you is to go and live your life and do what you're passionate about, and do your best not to worry about the defibrillator. I tell patients that defibrillator is like an airbag in your car. Hopefully you never need it, but you wouldn't drive a car without an airbag, right? But go on the trip. So do what you want to do. In terms of exercise, if your heart muscle has recovered and strong, and it's a good time to shout out to Cardiac Rehab, which is a great educational program after heart attacks for patients like you to go through, just to get kind of their sea legs again for exercise. But I think just regular aerobic exercise, 30 to 45 minutes a day, where you get your heart rate into that sweet spot of about 50 to 70% of your max heart rate. The easiest way to calculate your max heart rate is just take 220, subtract your age, and whatever number that is, just take 70% of that. That's kind of your peak heart rate that you want to sustain for that period of time. And do that 30 minutes a day, and you'll be in great shape.
Thanks, Nancy.
I line dance sometimes for 2 hours at a time. Perfect. And walk 10 to 20,000 steps a day. I swim, doing all, because I'm diabetic and I have peripheral artery disease. So the other question, is a watchman one of the things for me? I don't know, because I do have peripheral artery disease and I take Plavix and Xarelto.
Only if you have AFib. I think if you developed atrial fibrillation, that's a good conversation to have with your cardiologist. But without AFib, no, you wouldn't need a watchman.
Okay. I do see electrophysiologists at MUSC. So,
excellent.
Yeah.
Marcia, do you want to go ahead and unmute?
Yes. Thank you, Dr. Bumgarner. When I was diagnosed with PAD, I went and got an Apple Watch so I could monitor my walking and, some of my health issues. And when I did, I started like 4 or 5 times a week. In the morning, I would wake up and it would say I had AFib while I was sleeping. And so, long story short, I went and got eventually an ILR inserted, and it's really calmed down. But I quit wearing my watch at night, and it's not picking up. The ILR is not picking up nearly hardly any AFibs. What do you make of that?
Yeah, I think At the end of the day, the watch is doing the best it can to get a EKG signal from your wrist. But the loop recorder that you have inside, it's just it's a more sensitive detector. And I think I would take a little bit more peace of mind if that loop recorder is telling you that you don't have AFib. That's a pretty good. Those are really good algorithms in those devices, and so I think that.
I mean, it has detected them, just not nearly as many anymore.
Not as much, and that AFib starts as a small thing. It sort of comes and goes, and for a lot of people, it doesn't grow, it doesn't become a big problem. But for a lot of patients, it sort of hits this growth curve. After having it for 3, 4, 5 years, and it really starts to take off. So, certainly keep an eye on it. In case if it starts to increase, I think that's when you'd want to have it treated either with medicines or an ablation.
Thank you.
You're welcome.
Douglas, did you have another question for Dr. Bumgarner?
Yeah, the correlation between PAD and the heart and the symptoms, is there in AFib, the more we exercise, the better off that gets?
I think the right exercise, this idea of lifting as much weight as you possibly can and doing bench presses, and deadlifts up to 500 pounds. If you measure someone's aortic pressure when they're doing that, it's insanely high. That's not the kind of exercise. The kind of exercise that's really good for your heart is good aerobic daily exercise that doesn't overstress your heart, but just the usual goal that I'll tell patients is if you can exercise for 45 minutes and you hit a point where you can carry on a conversation, but you have to every once in a while take a deep breath, you're at a good spot.
We talk a lot about walking 30 minutes. 30 minutes. We got to walk 30 minutes to build those collaterals. Now, does the pace of our walking make that big a difference between the collaterals that we need to build in our heart and building our heart?
I'd probably defer to John on the collateral question.
I would say that when I tell people that what pace they need to walk for PAD, it's such that they get claudication or they get the discomfort, walk a little bit further and then rest. You need to walk to get the pain, I think, to develop the healthy collaterals. And then I also tell folks the same thing that Joe said, walk at a clip such that you can potentially talk to the person next to you, but it's a little uncomfortable. The whole kind of holding hands and, having a conversation, that doesn't do it, in my opinion.
That's a good question. We always get asked that because we have some patients that will say, I'm in cardiac rehab and I can't even literally make it 10 minutes where I have to stop. Am I getting the same cardiac benefits as a cardiac patient who doesn't have PAD and can make it and sustain those 30 minutes of a higher heart rate? And we have some doctors that will say, I will treat a patient with PAD so that they can sustain a certain pace and a certain heart rate for 30 minutes in order to maximize the benefits of cardiac rehab. And then I have other doctors who treat PAD that say, absolutely not going to treat them. They're just an intermittent claudicant. Their heart's fine. They'll still get the same benefits. And here are the patients caught right in between. And their life and limbs are in jeopardy. And there's no definitive agreement as to what to do. So what is your suggestion? What's your experience?
Anything's better than nothing. And and I'd push John a little bit on walking is not good. Walking's great. And there's data that there's some great studies out of England that show that you don't have to jog or run. You can walk. You just have to do it at sort of twice as long. You get the benefit a little faster when you're jogging and running. But if you walk, you cover the same distance. It's going to take longer. There have been comparison studies that show that the benefit is still there. I think that listening to your body is really important. It's the kind of thing that we don't have to train to become Olympic athletes to have a healthy heart and to have aerobic health. And I think just getting out there, making it a habit, each day, spending 30 minutes, just for yourself. It's good for your mind, it's good for your soul, it's good for your heart and your muscles. And we're meant to move. And I think just anything is better than nothing.
You were mentioning in one of the commercial breaks about the NBA, the athletes having, hearts that looked like they had some enlarged hearts. Is that something that is a concern for you when you see that? Is that healthy
Yes.
for them, or is that's something that is a concern for later on in life? So they get past their prime and then suddenly they dropped out of a heart attack in 10 years
Yes.
after they retire.
Those risks are there. There is some degree of normalization when they stop the intense exercise, but everything in their world is geared to get them bigger, stronger, faster, and there's no amount of advice you can give to a professional athlete at that level when it comes to that. It is a risk. But for me, that would be like someone coming in and saying, that X-ray machine that you're standing right next to is really dangerous. You probably shouldn't stand quite as close. But at the end of the day, it's our livelihood. So it's a huge issue. It really is. And this is why NFL players and NBA players, their life expectancies are shorter, and it's a big problem. And the system around them, what was so fascinating, when they would come in, they would get stress tests. And you think about doing a stress test and you want to do it to your maximal fatigue, they would absolutely not do that. As soon as they hit their peak heart rate, their agent or their coach would take them off the treadmill. They don't want to know. They don't want to know what happens. They don't want to see it. They're not there for the health. They're not there to see how healthy they are. They're just there to see that they're healthy enough to exercise, to do their job.
But I can tell just by your tone that that's concerning to you, being a doctor and knowing what you know.
It's the way of the world, isn't it? I mean, they're motivated by so many other things, but
do you think you could make a difference somehow in these athletes and their longevity if they would only max out right then and there so that they would know? And then that's where you can come in. The more you know, the more you as a doctor can come in and help them to not only prolong their career, but also prolong their life.
That's right. That's right. I think it's a great opportunity to build a relationship, to let them know that these are things they're going to need to follow through their life, that these are conversations they're going to need to continue to have. And I think just their awareness that they're not immortal and that their hearts will need to be cared for and monitored. There's been a lot of good work, a lot of initiatives that those professional organizations have done to get physicians at many different levels, mental health, cardiovascular health, all of these things. And so we go to the combines, we go to the drafts. There are physicians at all of those checkpoints now, and there didn't used to be.
Is there some advice that you can give, let's say, to parents and young athletes as they're just starting out in this journey? They realize that, I have a certain talent and I think I'm going to go all the way. What are some of the tests that, one, they should get ahead of time to make sure that their heart can withstand the endurance training that they're going to endure, and how much of it they can endure with their particular God-given bodies?
Yeah, I think that others may disagree with me, but I do think that teenagers that are in sports, they really do need an electrocardiogram at a bare minimum, a 12 lead EKG, and many of them also need an ultrasound of their heart, because there are patients out there that have cardiomyopathies and they don't know it. And one of the risks of having sudden cardiac arrest is strenuous exercise. And so doing that enough in athletes, you are going to pick up kids that could potentially die, on a basketball court while they're exercising. And the other side of that is we want to be a society that helps schools get defibrillators and put them in gyms and put them on football fields and have these defibrillators ready to go, because these kids, it's going to happen, and having trained personnel there ready to react is really, really important.
And it is so important, especially to be prepared to know your body and to do whatever you can and whatever insurance will potentially cover, right? To prepare for this endurance training. Because my younger brother is a really good example, that he ended up with the Arnold Schwarzenegger syndrome, is what I call it, the bicuspid valve defect. And he didn't know that until he literally the doctor said he was just months away from a heart attack, because he was doing massive weight training, and he was entering into what do you call those, bodybuilding competitions, and just going the extra mile, and it wasn't right for his body. And so he had to literally completely do a 180 there. And now he can no longer do that because his body's just not designed for it. But he should have known that before, and that's frustrating that he didn't know until it was almost too late. But at least it wasn't too late.
That's right. And not a completely painless, non-invasive test can pick that up. I'm glad they found that for him.
Yeah. I want to just turn to the audience. I don't want to keep you all day. It's a beautiful Saturday afternoon. Any other questions? I think Douglas wants to jump in.
Yeah.
Go ahead.
And you were talking about the treadmill thing. That reminds me of that football player that almost died on the field. I wonder if he got to that point and they said, no, we don't want to. If y'all had known that, could that have been prevented? You know what I'm saying?
I do. And I often, I use that example, that player from the Buffalo Bills, a lot of times when patients are deciding about, nobody wants a defibrillator, nobody. And so as they're thinking about it, often we'll talk about that event and how really what saved his life was the defibrillator. It wasn't, CPR helps and medicines help, but the thing that saved his life was the defibrillator. And you're right. Could he have gone just too far and too hard? And I think that what's been interesting about that, they never really released a lot of information about what caused that for him. And it brings a lot of questions to my mind about maybe what is going on there. But that just underscores again the importance of having a defibrillator ready or in a sports setting in case something like that happens, because it's so treatable, it's so reversible.
One more quick one. Atypical. Is there a way to describe what that would feel like in somebody, or is it different for everybody?
What would feel like?
The apical hypertrophic cardiomyopathy?
No, having that rhythm, that different rhythm.
Yeah.
You said earlier, some people know it and some people don't. My first thought was, how would you actually know if you were?
So for AFib, the most common symptom is fatigue, is feeling tired. And that is a hard symptom because there are so many things in our life that make us feel tired, and you can kind of brush off fatigue for weeks and months and maybe years and not react to it. A lot of people think it's going to be palpitations or chest pain or shortness of breath, but fatigue is by far the most common symptom and the most common reversible symptom when folks go back to normal rhythm. So I think just paying attention to your body, it's another reason to exercise. When you exercise, you're doing your own stress test every day. If something's changing, that's your way to pick up on it. Let your doctor know about it. So, if there's something going on, they can catch it and help you.
And we always say to the patients, don't argue for your own limitations. Don't make excuses. If you're feeling fatigued, take note of it. Don't just blame it on, last night I didn't have a good night's sleep. Okay, well, then last night I didn't have another good night. And then last night I didn't have another good night's sleep. Yeah. I'm just tired because of that. And that's what my dad did. And the cardiologist told him he was literally just months away from a massive heart attack. Yeah. Because he kept saying, well, no, I just have an excuse for this or that. Really take note of what your body's telling you. And I think that's the most important advice that you've offered, through this, along with so much other great information. Coming up right here on the Heart of Innovation, we have a couple more questions from our live studio audience. We'll get to those and more. So stay with us right here on the Heart of Innovation. Don't go away.
You have leg cramps that stop you in your tracks. Aching and tightening that always comes back. It could be your artery signaling something's wrong. Let's dive into this journey, come along. Walking down the street, feel the birds let in. See what struggles turning into fights within. Don't ignore the signs, your body's playing loud. Time to act now, stand up and be proud. Peripheral artery disease is more than just an ache. It's your heart's message, don't let it take a break. Seek the help you need, your life's worth the fight. With awareness and care, we'll make it right.
Time flies when you're having fun. We only have a few minutes left, so let's get back to our audience. We've got a couple of folks who have questions.
Okay, we're going to go to Douglas. Douglas, go ahead and unmute and ask your question.
Thank you for joining us. I'm 63. I have PAD. I've been diagnosed with atypical hydrotropic cardiomyopathy. I had a myectomy a year and a half ago, and my defibrillator went off 3 times in 10 minutes, like 3 days after my surgery. Now, I experienced points in life today where it feels like there's a vibrator in my heart that comes and goes. Does that sound anything like the doctor had mentioned one time I need to see electoral, but I haven't seen one yet?
Yeah, it can be really difficult to tell the sensation that you have in your heart if it's an electrical problem. But if you have a defibrillator, as you say, in your heart, the great news about that is that you have the best way of reading the electricity from within your heart. That device, if it's in the heart muscle, and there are some different variations on that, but if there are wires actually inside your heart, those wires can tell an electrophysiologist or a cardiologist exactly what those heart rhythms are doing at the precise moment that you're having those symptoms. If it is an electrical issue, it's pretty easy to see that. So I would encourage you to see an EP to look into that.
And Marcia has sent her question in. How reliable do you think Apple Watches are for AFib?
So that's a great question. And I would put Apple Watches and the KardioMobile on equal footing. We did some of the sort of initial comparison research for this at Cleveland Clinic, where we compared reading 12-lead EKGs to an Apple Watch, reading in 12-lead EKG to a KardioMobile. And essentially, those devices are about as good as the generated computer reading that you get from an automatic 12-lead EKG. When you have a cardiologist look at it, the sensitivity and specificity go up to almost 98, 99%. So what that really says is it creates a really clear tracing. The algorithms are really good, but to nail it down, having your cardiologist look at it too and confirm it really seals the diagnosis. But they are.
Go ahead.
Sorry, real quick. Should I be worried when my Apple Watch tells me my heart rate's less than 40?
I usually tell patients that God didn't give us a heart rate monitor, and we probably should take it off when we sleep.
But that dovetails into the thought with the athletes.
That's right.
Which what we alluded to at the beginning of the show, right?
Yeah, so we were talking earlier, why do athletes go into atrial fibrillation? And I think it's kind of two sides of a coin. They exercise really hard, and they're putting their hearts under a lot of stress for a long period of time. That might be part of it. But then the other side, most athletes have a really low resting heart rate in the 30s and the 40s. And so there's just a lot of time between each heartbeat that comes along where another pacemaker in the heart can wake up and start to fire electricity. And that's where those pulmonary veins, which are these bad pacemakers, these bad spark plugs, I think start to fill in some of those gaps on these athletes and fire inappropriately and trip them into AFib.
Now, when it comes to AFib, though, this is something that shouldn't be missed. This is something that if you go to your annual exam every year and the primary care physician puts their stethoscope to your heart, this is something that should not be overlooked. Am I correct? Or is this something that they can't detect?
So listening alone or feeling a pulse, that primary care doctor would pick up on an irregular pulse, and then they would need to confirm that with a full 12-lead EKG.
Okay.
But that is often the thing that tips the primary care doctor's ear to the possibility of an arrhythmia. And I agree with you. An annual exam for that reason is very important.
What do you think of those
Go ahead,
new echo stethoscopes? Have you heard the EKO stethoscopes, the world's smartest stethoscope? They're trying to get those into the hands of the primary care so they can be a little bit more in tune to these earlier signs of heart issues such as AFib.
It sounds like a good idea. It sounds expensive.
Yeah, 30 seconds left. I'll just say that a lot of us, because we have access to so much technology, the stethoscope may have gone the way of the dodo. But thanks for joining us. Have a fantastic weekend, everybody. Dr. Bumgarner, appreciate your time.